and I'm going to be a family nurse practitioner student for today. May I ask your first name and last initial?
William G.
Okay. Thank you, Mr. G. What brings you into the clinic today?
Just a checkup.
Okay. May I please perform a pulmonary or respiratory exam on you today?
Yes.
Thank you. So today we will be performing a pulmonary or respiratory exam on the patient. At this time, I will sanitize my hands and don my gloves. With assessing the respiratory or pulmonary system, we will start by first inspecting the anterior and posterior chest. For the sake of the patient's privacy, he will maintain a t-shirt on while doing this assessment, okay? But looking at the anterior chest, okay. Open your hands. Looking at the anterior chest, there's no obvious abnormalities, no obvious mass, lesions, or tears in the skin. Mr. G, are you currently having any pain, tenderness, or discomfort in your chest today?
No, ma'am.
Okay, thank you. Also, inspecting the posterior chest, just inspecting. There are no obvious lesions, tears, or obvious mass that are seen just with the naked eye on the patient's posterior chest. Mr. G, may I please ask, are you having any pain, tenderness, or discomfort in your back right now?
No, ma'am.
Okay, good. So after we inspect the chest, we will move on to auscultation. We will be listening to the anterior and the posterior chest, okay? Mr. G, when I listen to you, may I please ask you, with each touch of my stethoscope, may I please ask you to take a deep breath with your mouth open, please?
Okay.
Thank you. And I do want to first apologize that if I may sound a little muffled myself, but I have a little bit of congestion going on, but I'm trying to speak as loud and as clear as I can. At this time, we will start by listening to the anterior chest. I'm going to first start by listening up in the clavicle region. Good. Good. This is the second intercostal space. Good job. Moving down to the fourth intercostal space. And again, it would behoove you to listen to the patient up against the skin so you can get a clear hearing of it. One more time for me. Fourth intercostal space, listening to the middle lobes. Good job. Mid-clavicular. Good job. Listening to the base of the lungs. Alrighty. And then mid-axillary. Still listening to the base of the lungs. Thank you so much, Mr. G. No adventitious breath sounds heard whatsoever throughout the lung fields. Now we're going to listen to posteriorly. May I please ask you to turn to the opposite side? Thank you, thank you, thank you. And I'm going to move you here. Just like the anterior, we will start at the clavicle space and work our way down. Again, Mr. G, may I please ask you to take a deep breath with your mouth open as I listen to you posteriorly. And again, it will behoove you to listen with the stethoscope up against the patient's skin so that you can get the full effect and listen to the full breath sounds, okay, with nothing intervening like a t-shirt. And with women, you may have to, that are very well endowed, you may have to move the breasts to listen to the sounds, okay? Good. Mr. G, may I please raise your shirt?
Yes.
Okay, thank you. Good job. Thank you so much, Mr. G. There were no adventitious sounds heard there whatsoever in any of the lung fields. Clear sounds bilaterally, posterior as well as anterior. Next, we will be listening for bronchoscopy. With bronchoscopy, we will have the patient say the word football, okay? And when listening to bronchoscopy, the sound should not be clear throughout. It should get a little muffled as you work your way down posteriorly. If there is a clear sound throughout, it could be an indication that there is possible congestion or some type of pneumonia, okay? Again, Mr. G, I'm going to be listening again posteriorly for what we call bronchoscopy. May I please ask you, with each touch of my stethoscope, may I please ask you to say the word football?
Yes.
Thank you. And again, I will lift your shirt, okay?
Okay.
Thank you so much.
Football. 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 Football.
And with each, as we worked our way down the thoracic cavity, posterior thoracic cavity, it did get muffled. There was no adventitious sounds heard that I heard posteriorly either. Next, we will be listening for what we call egophony, okay? With egophony, we will have the patient say the word E, but a little prolonged with each touch of the stethoscope. We will be listening for adventitious breath sounds, as well as it should be muffled again as we work our way from the top to the bottom, okay? If it's clear throughout, then there is an indication that there's something wrong, maybe a possible mass, okay? Again, Mr. G, may I please ask you with each touch of my stethoscope to say the word E, but have it prolonged, almost like a singing E, like that, okay? All right, and we'll start with assessing for egophony.
E.
Good job.
E.
Good.
E. E.
Good.
E.
Good.
E.
Good job.
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 E.
Good job. And again, with each sound, it did get muffled as we worked our way down. Another thing is, if it starts to be sounds like an ah, like if you say ah, like if you stick out your tongue and let the provider look at the back of your throat, or like you're doing a strep test and you stick out your tongue and say ah, like that. If it starts to say ah, then that could also be an indication of a mass, okay? Remember, it's not when you're assessing for bronchoscopy or egophony is not supposed to be clear all the way down. It is supposed to sound muffled. And with egophony, if you start to get more of an ah instead of the e that the patient is saying, then that could be an indication of a possible mass, okay? Next, we will be listening for what we call whisper pectoriloquy. With a whisper pectoriloquy, we will have the patient whisper 99 with each touch of our stethoscope. And again, with each touch of our stethoscope, as we work our way down, that sound should become very faint. And if it does not become very faint, then that may be an indication that there may be a pneumonia or some type of respiratory issue, okay? Mr. G, may I please ask you, with every touch of my stethoscope, may I please ask you to whisper 99 for me?
Yes.
Okay, thank you. And again, it did get faint as I got further into the assessment down the posterior cavity. Again, if it does not get faint, then that could be an indication of some type of pneumonia or some type of congestion, okay? It can also be heard in patients with COPD, okay? Next, we will do our palpation, okay? Again, Mr. G, are you having any pain, tenderness, or discomfort in your posterior or anterior cavity?
No, ma'am.
Okay. May I please ask you to turn around for me? Thank you so much. Okay. With assessing the anterior cavity, we want to first assess our respiratory expansion, okay? I'm going to put my hands here. I'm going to try to do it so you can see it. I'm going to put my hands also, almost like this. And when you take a deep breath, as he inhale, it should expand and then deflate when he exhale, okay? And if they don't, what we're checking for to make sure it's symmetrical, okay? Make sure both of them expand and come back in when it deflates, okay? And I'm gonna, excuse me, kind of invading your privacy zone, okay? Alrighty. Can I to take deep breath in and move it out. One more time. And out. Good job. And respiratory expansion, both sides did expand, and you could probably see it in my hands. And then as he exhaled, it did go back in together. So I would say that his chest is very symmetrical. Okay. Next, we will be testing. Tactile fremitus. With tactile fremitus, I'm gonna place my hands on the patient's chest, and we're feeling for the vibration. If to make sure that there's a vibration on both sides, okay? If there's not a vibration on both sides, then that is an indication of an abnormality, okay? Mr. G, may I please ask you to say 99 again for me? And I'm going to place my hands in 3 spots on your chest, as well on the front as well as the back. Will that be okay?
Yes, ma'am.
Okay, thank you.
99.
Good.
99.
Good.
99.
Good job. May I please ask you to turn around? I'm sorry. Help you. Okay. Alrighty. And may I please ask you to repeat 99 again for me?
99.
Good.
99.
Good job.
99.
Good job. Tactile fremitus was assessed, and the vibration is felt on both bilaterally, interior as well as posterior. Next, we will be measuring the diaphragmic excursion. I'm glad we did the posterior last, because I'm gonna measure the diaphragmic excursion on the back side. With diaphragmic excursion, there should be a 3.5 to 5 centimeter difference in between each markings, okay? If there's an indication that there is more or less, it could indicate an abnormality. I'm gonna grab my pen. And I'm going to lightly tap on my middle finger, working my way down. May I please ask you to take your hands and pull them together like this and put them right between your legs. Good. And I ask them to do so that I can have the shoulder blades out of the way and have the spine midline, okay? Nothing in our way. We can move the shoulder blades out, okay? And again, I'm going to lightly tap. And that is about a 3.5 centimeter difference in the space. Next, I'm going to actually percuss the anterior as well as the posterior chest, okay? And I'm going to do so by lightly tapping the chest walls, okay? Mr. G, I'm going to lightly percuss the chest, the anterior as well as the posterior chest, okay? I will do your back side first, and then I will ask you to lie down for the remainder so that I'm able to do the anterior, okay?
Okay.
But I will assist you, okay? Starting with the clavicular. resonance or anything there. Everything is starting to get a little dull as you work your way down. May I please ask you to lie down for me and I will help you. There we go. And again, it's just a little bit better to percuss the chest, the anterior chest, while the patient is lying down, so it will be easier for you. Starting with the clavicular region. Second intercostal. Fourth. Midclavicular. Mid-axillary. I did it a second time in each field, sorry. I did it a second time in each field just so I can compare the two. No hyperresonance, no abnormal soundings. It did get a little dull as you got down closer towards the bottom. May I please help you sit up? Did you have any questions or concerns with your assessment on today?
No, ma'am.
Okay, based on just assessing the respiratory system, I did not hear any adventitious breath sounds. I didn't hear anything that will be of concern that we need to address post the assessment on today. But however, if you start to have any chest pain, discomfort, or any type of tenderness whatsoever, please don't hesitate to come back to the clinic or to give us a call if you have any questions or concerns about post the exam today, okay? That marks the end of my exam. Did you have any questions, even if it's not pertaining to the respiratory or the pulmonary system? Did you have any questions that you'd like to address at this time?
No, ma'am.
Okay, I do want to thank you for allowing me to perform a pulmonary exam on you today, okay?
Thank you.
Thank you. And again, that marks the end of my pulmonary and respiratory exam. Thank you so very much for your time.